This is not one. Hi everybody. Thanks for coming along tonight to this excellent event. So I'm delighted to welcome Katie Mowat,
Hello everybody, thank you Rachel for that introduction. It's good to see so many people in the audience here this evening. Some of you I recognise, I have met before, but some many new faces too. So my name is Katie Mowat, and I am Access Inclusion Health Officer for the British Deaf Association. I've been involved in a particular project for the last 3 years, and the goal of that project is to promote healthcare awareness among the deaf community. I'll be talking to you a little bit about the role of the British Deaf Association, my own role, and then specifically this health report, Access and Inclusion, a review of deaf British Sign Language users' engagement with healthcare in Scotland. So let me tell you a little bit about the BDA, the British Deaf Association. The vision of the BDA is that deaf people can fully participate and contribute as equal and valued citizens in wider society. We promote equal rights for deaf people, and the BDA works to ensure that deaf people are empowered to be more active citizens in order that they can achieve equality with wider society. The BDA campaigns for and empowers deaf people to demand their equal rights. And one of our aims is to secure equal human rights and justice for deaf people. So my role at the BDA is to work as the Access and Inclusion Health Officer. This is a funded role, a 3-year funded role, attached to a particular project. Previously, the project role had a different title, but now I'm referred to as the Access and Inclusion Health Officer. The goal of the project and my role in particular is to make sure that deaf people have equal and direct access to all forms of healthcare and promotion access across the whole of Scotland. So I work in conjunction with existing providers and professionals to ensure that all these services and information, advice and health promotion are all fully accessible in various formats to deaf people. The core aims of the project are to ensure that all deaf people have full access to health services, to make sure that deaf people have full involvement in their own healthcare, to improve access to information for deaf people whose preferred language or first language is British Sign Language, and to make sure that deaf people are involved in decisions about public services. Another aim is to include BSL and deaf awareness training for health professionals, and to help deaf people to communicate with service providers through health promotion and the voluntary sector, so that we can see that the deaf community members are working more closely with these various service providers. The success of this project can be demonstrated by the fact that we have conducted a survey research with 189 participants in 13 locations throughout Scotland, where we talk to deaf service users about their experiences of healthcare. It's also successful because we've given various presentations like this evening and given reports on health issues in the deaf community to various NHS health boards. And all of the presentations are evidence-based. We're able to demonstrate what deaf people tell us that they want and need. We provide information sessions to the deaf community on, for example, dementia, stroke, depression, Today was International Women's Day, and we had 70 women participate in an information session about health-related issues for women. We have produced BSL translations of various healthcare information clips, including information on depression, dementia, stroke, MS, ME, Parkinson's disease, and so on. We've also developed accompanying fact sheets on these kinds of healthcare conditions. And all of this information is accessible through our website. We've conducted forums and steering groups related to 5 different key health topics and working with different organisations to promote understanding about these various health conditions. And we worked in close partnership and through our networks with other deaf organisations and also health organisations. Throughout the research process, we attended 13 different deaf clubs or groups throughout Scotland. When I attended those deaf clubs, I would present information about our project and our survey, and would ask questions in BSL, and people could either respond directly in BSL, submit videos of themselves in BSL, or submit written responses. And we used a combination of different data collection techniques, including one-to-one interviews as well as focus groups. And all of the survey questions were translated into BSL and made available through our website, so people could access that information not only face-to-face when I was attending events, but also online, and also it's made it accessible for people outside of Scotland as well. In talking to various deaf BSL using participants in these different groups, you can see that we were able to talk to people in different contexts, so for example in group homes, but the largest number of participants were contacted individually through webcam online conversations, 68 people we conducted conversations with. Sometimes we found it hard to find people to talk to, but this is a summary on this chart of who we met in total. This is the recently launched second year report from the project, which we're required to produce as a result of our funding requirements from the Scottish Government. So in this report, we document all the experiences in relation to healthcare access that the deaf people have shared with us through the various interviews we've conducted. So this has meant that we could collect the necessary evidence to present in this report to represent the voice, if you like, of deaf people about their own concerns about healthcare in Scotland. And this information can be used to present back to the government. So what we did was talk to deaf BSL users about their experiences in primary and secondary care health context. So primary care, for example, with their local GP, where often they had regular visits, they knew the doctor, they could establish some form of communication, whereas in secondary healthcare settings such as hospitals, there's often a high turnover of staff, they don't see the same people every time, and they can't establish communicative techniques. For example, one deaf man said, I have no problems with my GP, because they always arrange to book BSL interpreters for my appointments. But another person said, well, when I went to hospital for an appointment, I didn't know the BSL interpreter. So what we found is that basically BSL interpreters are often not available in secondary care, especially audiology departments. A deaf woman in Glasgow said, I went to hospital for an appointment, but I didn't know who the BSL interpreter would be. And someone did arrive, but it was a man. And I was told that it was my right, that I had the right to choose the best appropriate interpreter for me, according to my health condition or whatever. We were also told that when NHS staff know them, that deaf people felt that communication is often better when services are more local. But when there's more staff rotation and therefore the staff don't know their needs, that's when they found communication difficult. One deaf woman said that she felt that all nurses and doctors needed deaf awareness training before starting work in GP surgeries or hospitals, that the medical students and nursing students should be exposed to that information before they meet deaf people in real life. One other aspect that we discussed was the referral system. And deaf people felt often they were given referrals, but didn't understand why they were given a referral, perhaps to go to hospital. And it was only once they got to hospital they understood what the referral was for, what the purpose of it was. They also reported that they had problems contacting the NHS. Perhaps they were given referrals and told to make appointments, but they had to phone to confirm their attendance, and sometimes they would just turn up and then told that because they hadn't phoned to confirm their attendance, the appointment would be cancelled. So there needs to be other options for deaf people to contact the NHS, either through fax or other means. Many deaf people also reported having to rely on family members to call the NHS on their behalf, but by the time they could do that in the evenings, the services were often closed because it was after 5 o'clock. One deaf woman reported that last time I went to my GP for an appointment, I had to explain my health problems without an interpreter. I had to write things down to discuss the problem. He mentioned that he would send a letter to the hospital for an appointment, but he never told me what it was for. I got a letter and went there, but no interpreter was provided for that day. So the doctor hadn't informed the hospital that this deaf woman needed an interpreter for her appointment. So whose responsibility is that? Many people have talked about feeling the need for other means of contact, such as through SMS or email, rather than relying only on the phone. We know now that Contact Scotland BSL is a service that's available for deaf sign language users to contact NHS24. And one person reported that they tried to access this service, but the screen kept freezing or disconnecting. So in the end, that person gave up. And now they say that they rely on their family or friends to call the GP or hospital on their behalf, which means they've lost their independence in relation to their own confidential, potentially, healthcare issues. Many of our deaf participants felt that their local healthcare services should develop more deaf awareness, and often they can develop more deaf awareness, but they still need to be informed about things like booking interpreters and how they can participate in basic communication with their deaf patients. They also said that they are happy to recommend local services. So, for example, if there are many deaf people living in a certain area who attend the same practice, then it means that practice, that people start that practice more familiar with dealing with deaf people, so deaf community members then recommend other deaf people to go to that same healthcare practice. And we know that we can't always guarantee the quality of healthcare services provided to deaf people, but in these situations it certainly helps. We also had some comments concerning ambulance patient transport services, PTS. Many people said they were unhappy with these services because they would request an ambulance at a particular time, but it would come and pick them up early, and they'd have to wait around for several hours until their appointments are available. Then they'd have to wait until the transport came and picked them up. So they were effectively out all day for a short appointment, so which meant that people often chose to get taxis instead because it was quicker and more expensive. One deaf woman who herself was a wheelchair user reported that the ambulance transport service actually said, we will come and pick you at 9:15 for a 12:15 appointment. So then she had to wait for several hours at the hospital before seeing the doctor. She then said, well, after the appointment, I asked the staff for ambulance transport to take me home, but they told me I had to wait till 4, so I didn't get home until 5. So now I go there by taxi, she says, which is easier and saves time. One other thing that she also said was that because she was deaf, she felt a sense of isolation and discomfort in using the ambulance transport service because she couldn't communicate with anybody. Another example is accident and emergency wards, where, as we know, there's often a lot of chaos, there's a lot going on, and staff don't always know how to communicate with deaf people and understand the different communication needs that someone might have, whether they should book an interpreter, whether it's face-to-face or online, whether the deaf person is capable of writing notes to communicate. One man who reported a case that he went with his daughter to A&E, and they had very negative experience. He said that there was no communication provision, there was no deaf awareness. From the time they were picked up in the ambulance to the point of discharge, there was no connection, no communication with the staff. We also found a strong identification of the need for mental health specific services for deaf people in Scotland. One person said, I find it upsetting that in Scotland we don't have mental health resource primarily to support deaf patients, but in England they do. And I've known people who are going through an incredibly difficult time, but they felt they had no option to seek treatment in England. So this meant that they were cut off from their support networks here in Scotland. We asked people to report how easy NHS staff were to communicate with, and so people reported that 22% of people would use their family or friends for support, 31% noted a failure to book interpreters, 69% said that some form of communication support was provided, and 44% said that there were issues raised about lack of deaf or BSL awareness amongst NHS staff. Of the participants that we spoke to, many of them reported the fact that the times when they felt they could communicate with NHS staff, it was in local settings where they went regularly to the same service and they knew the people there, that they encountered problems in other situations when the staff were not regular or they didn't know them, and so they couldn't establish communication strategies. And they also reported that often it seemed like NHS staff could not be bothered to organise interpreters on their behalf, that they found that was time-consuming and frustrating. So often they reported that they would bring family or friends with them in anticipation of the fact there would not be an interpreter available for them to communicate in that healthcare setting. Sometimes the deaf people reported that even if they reported that they had arrived for an appointment, the staff forgot that they had advised them they were deaf and maybe called their name out until they missed their appointment and nobody came to get them. They wanted to be treated equally to other people in being called for appointments and suggested things like visual announcement screens rather than relying on people calling out names. And that there should be basic deaf awareness training for all NHS staff. And although they felt there was some level of basic awareness, there needed to be more. To make staff aware, for example, that they could use some basic form of handwriting or like using written notes, but they could also use gestures and other forms of communication. But once they started getting technical, it was too difficult for deaf people to understand. I couldn't guarantee that they could understand, especially when medical jargon was being used.
For example, when we received a letter informing them that we had to go for a medical appointment at a hospital, they often found it difficult to understand, and sometimes the information was not sufficient. The GP had not explained sufficiently why they had to go to the hospital, perhaps for tests, blood tests, what procedures were, and so the deaf person often arrived at the hospital without knowing exactly what to expect when they got there. And then also, sometimes deaf people were expected to phone, to contact the hospital to confirm the appointment, which of course is problematic. And then when they did arrive, the staff there would complain that they hadn't phoned to confirm the appointment, which of course made the deaf person feel awkward. So there was a deaf person who had met a nurse after going to the GP and realised that she had to go and get an injection, an anaesthetic. She had problems with her stomach and required a colonoscopy to check what was going on. But the deaf woman herself didn't know that that procedure was going to happen. She was already concerned because she was in pain with stomach problems. So she wanted her mother to go with her to support her. But nobody had told her why she required this check. So she didn't know why she was going to the hospital or what the tests were for. So the requirement from deaf community is really that they are given a full explanation of what treatment to take, what the medication is for, how often they have to take it. It's very important. And all that the nurse said to this particular deaf person was, oh, it'll be fine, it'll be fine. And she ended up being a bit bewildered about what the whole situation was about. And you know, sometimes a deaf person might receive a referral letter to go to the hospital for a very small matter, but they might become really concerned about it and not realise until they get to the hospital that it is actually just a small thing. So I think there's a need for improved communication to reassure people in that situation. And often the deaf participants said that when they received information about health issues, they didn't understand the jargon that had been used in the communication, and that they would definitely prefer plain English. They would like more information, and they would like it presented clearly in a way they can understand. And quite often they reported that when they went for hospital appointments, no interpreter had been booked. So there was no information to meet their communication needs. The information had not been passed on from their GP to the hospital. And so sometimes it's internal communications within the NHS systems that need improvement as well. Well, we asked about how contact could be improved with the NHS. Previously we had NHS 24, and now Contact Scotland has been introduced as an improved communication method, but many deaf participants said they would prefer text communication, particularly with the local services. Sometimes they have tried to make phone contact, which has not been successful, even if phone's been engaged at a time when friends and family were available to make phone call for them. And so they would prefer face-to-face contact, although often the staff would prefer that they didn't. And one woman talked about her GP surgery saying that she had to use the phone, and she became increasingly agitated with this change in service provision. And she wanted to speak to the manager about what was happening because she was quite upset and felt that she had no choice and there was a barrier to her communication with her GP. She said, how can I possibly phone? I'm a deaf PSL user. So they weren't prepared to accept a change in their systems in those circumstances. Many of our participants had never heard of Contact Scotland and didn't know how it worked. And one of our participants had tried to use the online service, but encountered so many technological problems that they simply gave up. And eventually asked family and friends to contact the NHS for them. So I asked participants to explain what the problems were. They talked about a range of things. In relation to Contact Scotland, the screen had frozen, and sometimes they did not understand what the interpreter was talking about. In a 2D screen, it's difficult to pick up finger spelling, and that interaction or connection is not present. And some deaf participants were not confident that the on-screen interpreter always fully understood what they were saying. In an already anxiety-provoking situation, that just increased their anxiety. The quality of the screen image is not very good. They felt that led to increased mistakes. They felt that the process was not smooth and that the software was not fit for purpose. So, for example, one deaf person had used it at home and their internet connection was strong enough and it worked well. But when they went to the actual GP's office, the signal was not good. And that was because of their firewall, which affected the quality of reception. Most deaf participants were more comfortable with their primary care service providers because they were familiar with the people that worked there and the staff there were familiar with their communication needs. And they said particularly it was difficult for people in the north of Scotland or rural areas. Because referrals to hospital often result in having to travel long distances, for example to Aberdeen for a hospital appointment from a remote rural area, and they have to stay there perhaps for a long time until waiting for the appointment. They don't know the staff. So, for example, one deaf person had gone for a high blood pressure issue, expecting a child. And when she arrived, she expected that the interpreter would have been booked, but no interpreter had been provided. And she had to ask at the moment of her arrival for an interpreter. And the communication had to take place through pen and paper. And really the deaf lady was not satisfied with the service. She didn't know how to complain about it. And there are so many individuals involved, it's difficult to know what the pathway for complaints is. The problem with secondary care services is the rotation of staff. And sometimes there are centres they can walk into where they can get quick resolution to their problems, but it's difficult to deal with it there because there's so many different staff that it's very difficult to know and build up connections with all the range of departments. And the deaf person felt that they had to repeat the same information often, not only about the medical condition, but about the communication needs, which was not the case when they go to the local services. And sometimes contradictory information as well. Many participants were happy to recommend their local services because if they use them regularly, they become familiar with the staff that work there. And many of the local services have reasonable ESL and deaf awareness within the staff team, and they would encourage other members of the community to use those services. Many said they didn't recommend the secondary care services. They weren't therefore familiar with deaf people's needs. And often interpreters were not provided. And one of our participants said, I wouldn't recommend those services. They don't know how to service for me. They don't have deaf awareness, they don't provide interpreting support. And I've complained to the manager about the need for improvement, but I've heard nothing back, and really the services have not improved. So it's very difficult to develop trust in a service like that. And like I said before about patient transport services, people feel very limited with the access provided by them. And quite often they prefer to use a taxi for their hospital journeys. And they become a bit confused about the services that's provided. And as soon as the ambulance arrives and find they're dealing with a deaf person, there's an immediate communication breakdown. And those paramedic staff need deaf awareness training as well. And of course, you can't bring in a interpreter in for an emergency on the spot problem or in the ambulance. So really, I think a primary thing that emerged from the information we gathered is that there is a greater need for deaf awareness training in the NHS staff. And if you look at the chart, 118 participants had never used patient transport services, 11 had, and 47 were concerned that really paramedics were the first point of contact with the NHS services. Back to accident and emergency. 74 of our participants very rarely had used accident and emergency services. Some of them had, and that communication was often limited to writing on bits of paper or relying on friends and family to sort out communication access. 59 felt that some NHS staff had good BSL and deaf awareness, and they felt that areas for improvement would be the provision of equipment from like interpreting, and good plain English communication would help as well. So an iPad would be a good idea to aid communication for online interpreting services, and that plain English would help with any written communication. And that the hospital staff would be training in systems for booking BSL English interpreters. You can see the different percentages in the chart on the screen. So 74 people rarely went to A&E. But a lot of communication, 28, had used a writing pad or a family member or friend. 59 felt there should be more deaf awareness training, and those who had attended A&E were usually as a result of injuries. Moving on to knowledge about mental health services. Most deaf participants had a good range of knowledge, and that ranged from depression, self-harm, alcohol problems or drug problems, that they knew what those issues were. But 36 of our participants were not sure what those issues were. 138 were concerned that there was no residential provision here in Scotland for deaf people with mental health provision, for mental health issues. And they pointed out the fact that, of course, England does have such services. And some had been through mental health assessments and then had to go to a mainstream service mixing with hearing patients, and there wasn't a specialised service for deaf people. They wondered where they would go for counselling support if they suffered from depression or other mental health issues. But they felt that the services were not here, the specialist services. That there were not enough resources to support people in the area of mental health here in Scotland. In England, there's 2 separate provisions available, but none here in Scotland. And some had been through periods of crisis, and they felt they had no options in their treatment but to go to England. So there are limited services here in Scotland, but more choice is definitely required. And of course, when they have to go to England to receive treatment, they are cut off from their own support networks. 13 participants said that they knew a mental health professional, but they also knew that person socially as a friend, and that created issues around professional boundaries if they required treatment. And many of them would rather go to England where there's a situation where they weren't socially connected with the clinician. And one participant said, the community in Scotland is very small, and we all know each other. And really, that mental health services here in Scotland, really, they felt more staff should learn CBSL, and that deaf awareness should be improved across the range of staff. Can I just ask you, do you all know about pathways? Can I ask, do you know what it means? No, I mean, I asked our deaf participants that as well, and many of them did not know either. So pathway support, it really starts at the point of diagnosis. For example, cancer. A person has gone to the GP initially, and then the treatment process starts. And whether that is recovery, or whether it ends in death, unfortunately, there's a pathway that is follows the person through that course of treatment for diagnosis. But where's a deaf person going to find that kind of support? It's very difficult, and again, England has that, but not as well developed in Scotland. One woman talked about her 18-year-old daughter, and she had to care for her until the end of her life with cancer. There were lots of different support services, but the information was not available to the deaf person who was in that situation. And even now, she is angry about that time, because she wanted to be able to support her daughter better, and she felt she would be able to do that had she had more access to information. And I was her mother, she said, and yet I was not included in the full information. Another participant didn't know about pathways and about the availability of the range of care that is available to support patients. And it would be good if that information was passed on right at the start when they see their GP for the first time. 156 participants did not know about pathway support for the long-term care. Only 7 did, which is a tiny amount.
So let me move on now to the recommendations that feature in our report. There are 8 recommendations. One of the key recommendations concerns booking of interpreters. So basically, we've said that communication between primary and secondary caregivers needs to improve, and systems need to be established in order to ensure that information about deaf patients is communicated between services and the fact that they need interpreters booked for appointments. We also asserted that interpreters that are booked need to meet the needs of the deaf patients, and that ideally, if a deaf patient is having ongoing treatment, for example chemotherapy, they would have a regular interpreter with them every time, who's familiar with the treatment process and the deaf patient themselves. And then, so we felt that there should be some kind of identifier in the caseload, whether that's on the computer or in files, to identify that a patient is deaf, so that immediately, as soon as a referral is given or an appointment is made, that deaf person is identified and an interpreter is booked. In relation to the use of online BSL interpreting services, many of the patients expressed, or our participants expressed concerns that face-to-face services would be overtaken by video remote interpreting services, and they felt that although access to immediate interpreters through an online service could be beneficial as a short-term, more immediate solution, until an interpreter could be provided in a face-to-face, on-site situation. Because many people complained that going to an online service, it limited their capacity to have a sort of dialogue with the people, conversation with the people who were treating them in the healthcare context. They felt it was more one-way communication when it was through a video remote interpreter. And so basically, offering people the choice between an interpreter present in a real situation, a face-to-face situation, or an online version is something that should be offered to all deaf people. Second recommendation concerns training and the provision of BSL deaf awareness training for staff, especially secondary care staff, because of the staff rotation issues we mentioned earlier. We also wanted to consider basic deaf awareness training for paramedics and ambulance staff, so they could have an understanding of how to communicate with deaf patients when they respond to an emergency. So, for example, if somebody was experiencing a heart attack, they could at least identify basic communicative issues and perhaps use an iPad or another device to provide an interpreter online on the spot for an immediate diagnosis or treatment until they arrived at the A&E. And they could also use this online facility to request an interpreter ahead of arriving at hospital. So when they arrive with a patient in an ambulance, they wouldn't have to sit around waiting for an interpreter to arrive. They've already been called beforehand. The third recommendation is in relation to technological equipment. And we know that technology will improve over time, but we felt that there's a need for improvement in research and provision of information in BSL on various healthcare issues for the community using technology to provide that information. So, for example, more information with the pathway service, liaison with the pathway service about what happens for deaf community members, alternative measures for deaf people to confirm attendance at appointments or to cancel appointments, especially using text messaging. Because the NHS staff prefer phone communication, they still tend to over-rely on that form of communication and don't necessarily accept responsibility for checking and communicating with deaf sign languages, perhaps through mobile phones and texting, or through other devices such as iPads or online interpreting service. So we need to ensure that equipment is available. As I mentioned, the online interpreting service through an iPad or something, we need to make sure that technology is available on site so that it can access various forms of communication, and that the staff members at A&E have awareness of what's needed. The next recommendation is in relation to community representation. Some of you might be aware of the Health Watch model, which is an English model. And this basically means that people can represent community members and liaise with health boards. So we would recommend that we establish some kind of Health Watch model for the deaf community here in Scotland. So that would actually improve communication and contact between deaf community members and NHS staff. This would mean appointing deaf BSL champions who could liaise between health boards and deaf community members and provide training for both groups. We recommend that NHS focus groups should continue and be rolled out across regions as appropriate, but ensure there is deaf community representation at those focus groups to give feedback to the NHS. So, for example, providing interpreters at those focus groups. We also recommend the consideration for the establishment of a mental health service for deaf people in Scotland, such as they have in the UK. There's the John Denmark Unit, the National Deaf Services in London. Then those would be useful models for us to employ here in Scotland. And although some people reported that they didn't necessarily see the need for a deaf-specific service, but they did want to ensure that BSL interpreters were available if they were to attend mainstream mental health services. And sometimes that might be more appropriate because they didn't want members of the deaf community to know their business if they went to a deaf-specific service, but they were concerned about the quality of the interpreting provision and their communication access in a mainstream service. So that's my contact information, and thank you very much. Thank you, Katie, for your very powerful presentation. It's very interesting to hear about your survey research. Do we have anybody who would like to ask a question, make a comment? You have to come to the front, please. Someone like to ask a question? Thank you, that's very interesting. Am I too short? You see me on camera? So I was saying that's very interesting. And many of your recounts mirror my own experiences, but one thing I did find shocking was about the pathway service. I didn't know about that service myself. I was surprised to hear about that service. So where are they based? And is it an organisation? Could you tell us a little bit more about that?
Really, pathways has a whole range of elements to it. If you imagine the diagnosis of a person, right at the start of the treatment process. So first is the diagnosis, then treatment is identified, it starts. That might be an operation which requires consultation with a range of medical professionals. And so it's a notion of support from the start of the patient's journey right to the end, whatever that might be. I know, for example, in Liverpool, there's a pathway service for people who have terminal illness. It starts at diagnosis, goes through the treatment process, and really it supports patients as they go through the final stages of life. And that is the pathway service. But really it's a new concept here in Scotland, so we need, I think, to learn more about it. But if, for example, I had cancer, and I go and I discuss the problem that I'm experiencing with my GP, he will refer me to the hospital for assessment and tests, and they diagnose that I have cancer. Then I would have a consultancy appointment, and they would say, well, you need this, chemotherapy, radiotherapy, whatever it is, and perhaps an operation. And then after the operation, I will continue with chemotherapy. And then this is the outcome of that, whether it's been successful or not. And there's all the range of cancers, of course, that could be diagnosed. And so it's important that the pathways process supports the deaf person to make sure they have the full information about the specific condition that they have, that they get access to group counselling, support groups, whether that's over long term or short term. And then, of course, perhaps towards the end of the pathway, they will require more equipment, like a specialist bed, or additional support, or additional medication, right to the end of this process, right to the end of their involvement with the NHS. For example, dementia. That's another example. When they go to see their GP, and that's the initial diagnosis. But of course, the condition will be expected to deteriorate over time. And that's where support comes in useful from groups like support groups, counselling for the deaf person and the family carers. But the deaf people don't access that kind of service unless there's a specialist provision put in place. So that's really what pathways are. And I mean, like you, at first, I did not know what pathways were, so I'm learning about it, so thank you.
I wonder whether it's worth creating a video clip or something in BSL to inform the deaf community about that.
Yes. There's been the COPD, and that's a lung disease centre, and it's been very difficult to deal with the process there. And I met a person that had that, and you know, she had told me her experiences of the information and trying to access it in English regarding to her condition, and she struggled with that. And then when she watched signed information to camera, she just felt such a relief that she was able to access the information that she needed. And I had a similar discussion with someone who had suffered a stroke. And I know you can access a lot of information on the health websites, but really, without translating that to BSL, it's very difficult for members of the deaf community to access that.
I know that you can access information, for example, through NHS choices, but we need to think about how we translate that information to BSL, or at least summarise some of the key points for that healthcare information. I know it's part of my job to do something similar. But I think the fact that sometimes information that's available is also slightly out of date, so we need to check with the NHS whether the information is still current, because obviously we take a risk that if we translate something into BSL, then we could then be sharing incorrect information, and we don't want to be blamed for misinforming their communities, and it's something we need to be careful of. Thank you, Casey, for your presentation. I have a few questions to ask you. So you mentioned that you had 189 respondents. So is that the limit, or do you plan to interview more people?
Yep, we had 189. We're now into the third year of the project, and the notion is to review the survey that has taken place in the first and second year. So really, I want to review whether the questions were appropriate and whether the feedback has been sufficient, and then all of that's going to be compiled into a final report.
And I'm interested in who is observing you doing the research. So are you working with someone in collaboration on the research project?
Well, the Scottish Government funded the BDA to do this, and of course I work closely with my manager. And we have to consider, of course, that we've got all the right participants from within the NHS. We've asked their advice whether the questions that we asked are the right ones.
And the reason that I asked that is because you talked about discussing mental health issues with deaf people, and the fact they said they wanted services the same as which are available in England. Now, I know that SCOD and other bodies have also done similar kinds of research and to collect evidence for lobbying for Scottish specific services. So I just wonder how much you refer back to previous research that's been done, because there is existing information there which would also support the claims. And I know that the responses to previous research has been that it's not worth establishing a Scottish specific service because there aren't sufficient numbers to warrant such a specific service. So likewise, many deaf people said they don't want to travel all the way to England, but then if we established a Scottish specific service in Glasgow for other people living in other parts of Scotland, Aberdeen, Orkney and so on, it's still too far for them to travel, and they still prefer to access local services. So I know that in previous years, we have actually made recommendations for deaf people to stay local in their community, and I think the SCOD have made those recommendations, so I think it would be worthwhile referring back to some of that information.
And I think the fact is that there's such a dearth of information within the community that we're really at the early stages of gathering respondents' views on that issue.
I'd like to congratulate you on your research, and I know that you have another year to go. So could you tell us what the implications will be from the research? For example, the Scottish Government, what will the impact be?
I've had discussions with my manager, really, about what the next stage is for this work. So should we ask for an extension of funding from the Scottish Government, or should we change focus in where we're going with our research? But I feel there hasn't been enough work done yet in this area. We've made progress, but we haven't quite got there yet, and I'd love to see it continue so that we can take it even further.
Congratulations on the project. I think it's an excellent project, and I'd like to congratulate you on that. 3 years is not enough, you're right. Any more questions? That was really interesting, but I think there are a few problems that I see. First is funding. The second is people feeling like they don't want to take responsibility for meeting the needs of their community, and also the lack of awareness that we see in the NHS. Surely these are problems.
I mean, money, of course, is an issue. What was the second one that you mentioned? People not wanting to take responsibility for these issues and lack of knowledge. I think that a lot of the people really are not taking responsibility for these gaps in services. Is that what you meant? Is that right?
So I tried. Whether the issue is, because it seems really obvious that these problems shouldn't happen, and I was wondering what you see as the source of the problem, whether it's that the organisations sort of refuse to help, they don't see it as an issue, or they don't want to help. Is it that they're saying they'd love to help but they don't have the money to do so? Or is it just ignorance that they aren't aware enough to put the provisions in place to sort out the problems?
I think it depends on the area, really. In talking to people from health services, often they do say it's a lack of resource, lack of money to be able to provide specific services, even if there is a will to do it. For example, in Glasgow, they say they have a budget to meet the needs of deaf patients in their location. But other healthcare providers, other regions say they don't have a budget allocated to them, even though Glasgow does. So that's one issue, yes. I think also it could be lack of awareness. People just generally not knowing what to do when a deaf patient turns up. So I think it could be for various reasons. Me again, sorry. One more question. You said that most of the responses were very negative, but I know that I personally have had some very positive experiences with the healthcare services. Did you have any positive responses so that you can offer more of a balance?
Yes, I mean, some of the data extracts that we've used as quotes have been very positive. You know, talking about the local GP services, regularly providing interpreting services, and how they developed a good relationship with their local GP services. For example, in Shetland, Joy in the north, is an example of a doctor who was very happy to use all sorts of communication methods, pen and paper and gesture, but the priority was to make sure that he met his patient's communication needs. So that was very positive. I have to say that the vast majority of responses were negative. There were a few, but really just a few positive responses. Some examples where a patient went on to a support group and interpreters regularly provided. Sometimes excuses were made about the lack of interpreter because there was not sufficient funding. So how we're going to turn that negative experience into a positive, I think is one of the big questions for our future work. And really, I think that's one of our priorities in campaigning with the NHS, that we want the members of the deaf community to promote positive experiences with the NHS. So hopefully in the future, services will improve and we will get respondents giving us more positive experiences. And the BSL Act certainly help with that. Any more? No? Okay. We will bring the evening to a close. Thank you so much, Katie, for your presentation. Thank you for responding to all the various questions. Thank you everybody for attending. The next EdSign lecture will be in April, I think the 24th of April. Is it Tuesday 24th? Maybe 28th, or just, Ella's just going to double check the dates so we can confirm. I know the topic, well, I can't remember the date, so it's the 26th.
And we have a French presenter, Sylvian Keshin, who's hearing himself, has done research into subtitling for deaf and hard of hearing viewers. And he's at Strasbourg University. And in particular, his area of interest is looking at re-speaking rather than traditional subtitling. So he's French himself, and he'll be talking about his own research and comparing the situation in France and also here in the UK. And we know we've had subtitling available since the 1980s, so it'll be interesting for us to hear about that. And we'll have speech-to-text service provided at that lecture, so people who are non-sign language users will also be able to access the lecture. We'll also have theatre interpreters as well, of course. So hopefully you'll be able to attend that event, and we'll see you then. Thank you all for coming. Thanks again to Katie. Oh, any questions? Just to let you know, on the 15th of March, we're having a sign and dine night. Harriet Watts are organising it, and it's in Dalry at the Entwistle restaurant, pizzeria restaurant, and everybody's welcome. Starts at 6:30 until closing. The students and anybody else who wants to come. If you want some information, you can find out more information through our Facebook page, and we have some information here at the front. Okay, thank you. Sorry, I know everyone's desperate to leave, wants to go home. Also on March the 31st, Harriet Watt University is organising a research showcase evening. So we'll have a mixture of PhD students and staff presenting briefly about their current research. And we'll be having our own fourth year interpreting students who will be interpreting for those presentations throughout the evening. So if you're curious to see who our students are, come check them out, but also come to find out more about the research that we're doing at Harriet Watt University and come and support all these students. See you there.